This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the Child's Nervous System Journal, set to be published in 2026. It's titled Surgical Reevaluation Patterns Among Pediatric Vagus Nerve Stimulation Non-Responders, a single-center retrospective study.
This is a topic that hits close to home for anyone in pediatric epilepsy. We often treat drug-resistant epilepsy, or DRE, which we define as the persistence of seizures despite two or more appropriately chosen and adequately trialed anti-seizure medications. For many of these kids, when they aren't candidates for resection or ablation, we turn to vagus nerve stimulation, or VNS.
Exactly. VNS is FDA approved for children aged 4 to 18. It involves placing helical coil electrodes around the left vagus nerve, connected to an internal pulse generator in the chest. It's a staple for patients with non-localizable, multifocal, or bilateral seizure onset. But the problem the authors, Mossner and colleagues, highlight is what happens when it doesn't work.
Right. We generally define responders as those achieving a 50% or greater reduction in seizure frequency. Statistically, that's about 57% of patients after 2.5 years, but that leaves nearly half, about 43%, as non-responders. In clinical practice, there's this unspoken assumption that if VNS fails, we've reached the end of the surgical road.
And that's exactly what the study investigated. They performed a retrospective review at a single center, the Anne and Robert H. Lurie Children's Hospital, looking at patients who underwent VNS implantation between 2013 and 2020. They wanted to see how many non-responders were actually being reevaluated for further surgical options.
Let's look at the cohort. They had 47 patients who met the inclusion criteria. It was a fairly even split. 25 were responders and 22 were non-responders. Alara, did they find any significant demographic differences between the two groups?
Actually, no. There were no significant differences in age, sex, race, or even the operating surgeon. They also looked at the VNS generator model and the revision history. Nothing there either. Even the baseline anti-seizure medication, or ASM, burden was similar between both groups at the start.
That's an important point for the residents listening. You can't necessarily predict who will respond based on their initial clinical profile or the device model used. However, the outcomes did diverge during follow-up, didn't they?
They did. One of the primary secondary outcomes was ASM burden. At the follow-up, the responders required significantly fewer anti-seizure medications than the non-responders, with a p-value of 0.03. This suggests that a successful VNS response might allow for a reduction in polypharmacy, which is a huge win for a child's cognitive development and quality of life.
But let's get to the meat of the study, the reevaluation of those 22 non-responders. This is the part that should give us all pause.
It's quite striking. Among those 22 non-responders, only 3 patients, that's just 13.6%, underwent additional epilepsy surgery.
Only 13.6%. In a comprehensive epilepsy program, you would expect a higher rate of reevaluation for kids who are still having uncontrolled seizures. What happened to those 3 patients?
That's the interesting part. 2 of them underwent responsive neurostimulation, or RNS, and 1 underwent a corpus callosotomy. All 3 of them achieved meaningful seizure reduction postoperatively. So even though they failed VNS, they weren't unsalvageable from a surgical perspective.
And that's the tragedy of the exhausted options mindset. If these 3 had successful outcomes with RNS or a callosotomy, it begs the question, what about the other 19 non-responders who were never reevaluated?
The paper emphasizes the stakes here. DRE carries immense morbidity, cognitive decline, physical injury, and reduced quality of life. But the mortality data they cited was particularly sobering. In their non-responder group, there were 3 deaths. None were surgery-related, but they highlight the inherent risk of uncontrolled epilepsy.
They actually referenced a massive cohort study of over 18,000 children to put this in context. The 10-year survival rates are telling: 98.54% for those who underwent cranial epilepsy surgery, 92.65% for VNS-treated patients, and only 89.27% for those managed medically. The hazard ratio for all-cause mortality is significantly lower for surgery. So by not reevaluating these VNS non-responders, we might be leaving them in that higher-risk medical management pool.
Exactly. The author suggests that many of these children are managed in a medical silo after VNS fails. They are seen by their neurologists, the VNS settings are adjusted repeatedly, and because they already had surgery once, the idea of a second evaluation often falls off the radar.
It's a call to action for us as surgeons to stay involved. We need to be part of a structured follow-up pathway. If a patient hasn't reached that 50% reduction mark within a year or two of VNS implantation, that should trigger an automatic multidisciplinary reassessment. We need to ask, has their semiology changed? Has new imaging technology, like higher resolution MRI or advanced PET, revealed a lesion we missed before? Is RNS or DBS now an option for them?
And the study notes that the technology is evolving so fast. A patient who wasn't a candidate for RNS in 2015 might be a perfect candidate in 2026. The authors are very clear. VNS failure should not be the end of the line. It should be a milestone that prompts a new search for a solution.
For the residents and students listening, why do you think the ASM burden stayed higher in the non-responders?
The paper suggests that when VNS fails to control seizures, clinicians are more likely to add more medications to try to gain control. This leads to a higher side effect profile and further impacts the child's quality of life, whereas responders can sometimes be weaned off some of their more sedating medications.
It's a vicious cycle. More seizures lead to more meds, which lead to more side effects and still no seizure freedom.
One limitation the authors mentioned was the single-center nature of the study and the relatively small sample size, 47 patients. However, the trend is quite clear and likely reflects a broader pattern in neurosurgical practice.
It definitely does. It highlights a gap in our current comprehensive care. We are great at the initial workup, but we need to get better at the reworkup. The conclusion of the paper really sums it up. Structured follow-up pathways are needed to ensure timely surgical reassessment of pediatric VNS non-responders.
They also mentioned that all 3 patients who did get further surgery had favorable outcomes. That's a small number, but it's a powerful proof of concept.
It shows that the non-responder label is often about the device, not the patient's potential for improvement. Just because the vagus nerve wasn't the right gateway doesn't mean there isn't another one.
Before we wrap up, Eris, any final thoughts on how this changes a resident's approach in the clinic?
When you see a VNS patient for a follow-up, don't just ask, is the device working, or are there any voice changes? Look at the seizure log. If they aren't a responder by the 1-year mark, don't just keep turning up the milliamps. Start the conversation with the epileptologists about a new phase 1 evaluation. Don't let them fall into that 86% that never gets another look.
Well said. This study is a great reminder that our job as neurosurgeons isn't just to implant hardware, it's to advocate for the best long-term outcomes for these children.
Absolutely. That's all the time we have for today. Thank you, Dr. Alara, for breaking down this important study.
Thanks for having me, Dr. Eris.
And thank you all for listening to the Neurosurgery Hub podcast. We'll see you in the next episode. Stay sharp.